Perfect, thank you. I want to congratulate the organizers on this beautiful congress, mainly devoted to lamellar surgery. DALK is the present of anterior lamellar surgery. We all know the advantages over PK. The big bubble technique is the most widely used DALK technique by surgeons because it allows for good exposure of decimate. As compared to pre-decimatic techniques, we have a more regular surface, which translates into a better visual acuity recovery. As many registries, like the registry of Piedmont report, DALK is pretty rare. This is the data from the annual report of the Eye Bank Association of America for 2015. 2015, DALK was performed in 2.5% of all cornea transplantation. Anyway, it is a difficult technique. This is the main obstacle to the spreading of this method. If we look at the data of many studies from 2007 to 2015 with over 50 undergoing big bubble technique, in the red column you read that the conversion rates range between 20 and 30%. It means that 2 out of 3 surgeries are converted into manual DALK or PK. And some studies also report rates as high as 40%. And the presence of deep scars, early perforation of decimate membranes, and stromal emphysema during forced air injection are the commonest causes of failure of decimate exposure. In 2007, Ton and Mehta described this modified Anwar buckle technique. They suggest to remove stroma. The initial removal of anterior stroma allows for better controlled access to posterior stroma and to be closer to decimate's membrane so that stroma can be detached more easily. Personally, I started using this method in 2013. In this study, I report a series of patients undergoing this method in the eye clinic of University of Turin. These are the eligibility criteria. These are corneas. Minimum thickness was 350 micron. 88 patients, 92 eyes. Indications were mainly keratoconus, but there was also quite a high number of infectious keratitis. Mean follow-up is 17 months in this series. And this is my video, trephination with an Esper Baron manual trephine, you see. Then there is anterior keratectomy, as described in the original technique by Tan and Mehta. 50% of the stroma is removed. After finishing the anterior keratectomy with the pressure knife, we use a ad hoc dissector designed by Fogler. You enter the deep stroma. This path is then used to introduce the cannula and inject air. This is the Fontana cannula, and in this case, we use this cannula. It is then positioned centrally, close to the thinnest area. The big bubble is formed. The removal of the residual stroma is performed, and then the standard technique continues. Stroma incision posteriorly, and protection by viscoelastic, and then dissection in the 4 quadrants. In this case, the first step is done with the spatula and then with blunt scissors. After removing stroma, after finishing stroma, the flap is placed, and this is our suture. Well, these are the results. Data analysis, rate of big bubble formation and conversion, bubble type, and then we see the post-op complications. This is some data. Big bubble formation 80%, 74 out of 92 eyes, a single air injection in 64% of the cases, conversion rate 20%, almost 20%. Uncorrected distance visual acuity significantly improves. Best corrected distance visual acuity, you see, there is a marked improvement. Corrected distance visual acuity is over 5 on 10 in most patients, and in the graph you realize that in patients undergoing manual DALK on your right, visual acuity is significantly lower than the cases where big bubble works. Topographic astigmatism on average was 3.4 diopters. In 50% of our patients it was less than 3 diopters, while it was high, over 5 diopters in 14% of the cases, and these are the main complications. In conclusion, in comparison with the Anwar big bubble technique, this modified technique with initial anterior keratectomy might allow for more precise positioning of the cannula to inject air close to the descemet membrane. And in our experience, success rate is 80%. Consider that our cases also include many cases of advanced keratoconus. I'd like to conclude by thanking you for your very kind attention.